Good afternoon, and welcome to this webcast of the Houston Methodist DEBAKEY Cardiovascular Journal. I'm Miguel Quiñones, the editor-in-chief of the journal. And for those of you who might be first users of the journal, I would like you to visit us at journal.houstonmethodist.org, or if you prefer, just Google DEBAKEY CV journal. Tonight we're going to talk about the topic that the journal is covering at this time, which is restrictive cardiomyopathies, and in particular cardiac amyloidosis and sarcoidosis. Those are two diseases that for years were thought to be very rare. In fact, many practicing cardiologists say, I rarely ever see a case like that. But it turns out that with all the new diagnostic tools we have, we're discovering that both of these diseases are a lot more common than we thought. And also a lot of progress is being made in detecting them, diagnosing them, but importantly, managing them. So tonight I'm joined by the two guest editors that put this issue together. And they did a magnificent job. And I really, again, encourage you all to come to the journal and read the articles, although we hope that tonight you will learn something about it too. So I'd like to welcome Dr. Barry Trachtenberg and Dr. Mahwash Kassi. Both are heart failure specialists and both have a lot of expertise in managing these diseases. And as I said earlier, they did a great job putting this particular issue of the journal together. I also want to encourage you to ask questions, and you can do that by texting DEBAKEY to 37607. So without any further delay, Barry, Mahwash, you're on.
Thank you, Dr. Q.
So we're going to first start with our first guest, who is our amazing future chief fellow, Dr. Miguel A. She and Dr. Hussain put together an overview of restrictive cardiomyopathy. That's how we get started on this particular journal. And Barry, do you want to ask her the first question?
Yeah, thank you for joining us, Dr. Lee. I know Dr. Hussain wanted to be here but couldn't join us. And I know that you and Dr. Gala and Dr. Hussain put together this great review. And I think the purpose of this was to kind of help people understand what the term means when you use the term restrictive cardiomyopathy. I think there's a lot of confusion about that term. Can you tell us what the term restrictive cardiomyopathy means?
Right. Yeah. So restrictive cardiomyopathy, the reason why I think there can be a bit of confusion is that it encompasses a very diverse group of diseases, but joined by a common hemodynamic definition. So due to increased myocardial stiffness, there is severe LV relaxation impairment and diastolic dysfunction. It can range from anything like amyloidosis and sarcoidosis to others that are rarer, like storage disorders. So it encompasses a very diverse set of pathophysiologies and pathologies here.
Thank you, AJ, for that. And there's an excellent table in the journal's first article that goes over the different etiologies of restrictive cardiomyopathies. Now, there is an algorithm that you put together, and I would like you to go over it with us in the audience to kind of go over what basically do we need to do to diagnose these patients.
Yes, absolutely. So this chart, as we were making it, it brings, I think, drives home the point of the diverse set of disorders, as I mentioned. One key sort of step here is the echocardiogram to start our diagnostic and differential. Interestingly, when we think about restrictive cardiomyopathies, we think that the LV wall thickness is always very high, but in fact, the LV wall thickness can be low too. And in the category of the low LV wall thickness falls diseases such as idiopathic RCM or familial or genetic RCM, as well as the iron overload cardiomyopathies and radiation-induced disease. Endomyocardial fibrosis, this is a condition that is more endemic in places like Brazil, Uganda, so history is very key here. And then hypereosinophilic syndromes. When we switch our gears to looking at those patients with increased LV wall thickness, these patients, you want to make sure that we ask about drug exposure. So hydroxychloroquine is one drug that we know is indicated. So this patients typically, after getting a cardiac MRI, will go on to have an myocardial biopsy. And then otherwise, thinking of young patients, you may consider Fabry's disease or storage disorders, and of course, amyloidosis and sarcoidosis. So CMR is one of the, I think, helpful tests to follow up an echo, but it is very key to get that clinical history of familial history and any drug exposures or radiation exposure as well.
Thank you, AJ, for that excellent overview. So it broadly, I mean, it seems like family history, very detailed personal history, physical examination, and putting together echo and MRI help come to the diagnosis. Now, Barry, do you want to move on to the rest guest?
Yeah, thank you, AJ. We may come back to you, so stay tuned. Our next article in the journal was authored, senior author was Professor Daniel Judge from the Medical University of South Carolina. And unfortunately, Dr. Judge is not able to be here tonight, so I'm going to answer a couple questions on his behalf based on the article that was written by him and his colleagues at the Medical University of South Carolina.
So,
and sorry, that article was on ATTR or transthyretin amyloidosis, the epidemiology, the prognosis, and the genetics of the disease.
So I'm going to ask you some of those questions pertinent to this article. So how common is TTR amyloidosis?
So that's a great question. It's a difficult one to answer. I can tell you that hereditary ATTR is estimated to have approximately 50,000 person prevalence around the world, but that's probably underestimated. For example, in the United States, 3 to 4% of African Americans carry the gene, for the Val142 isoleucine gene, with an incomplete penetrance and really not completely understood what that penetrance is. So it's probably higher than that. But wild type TTR is much more common than hereditary. It's much more common than we realize, and more data points are indicating that we're missing a lot of these patients. There was a paper from Hopkins where they biopsied consecutive patients with HFpEF, and 14% of them had amyloid, which is predominantly wild type TTR. There's data from patients undergoing a TAVR evaluation with aortic stenosis, and perhaps 16% of those patients have TTR amyloidosis. And it's estimated in this article that perhaps about 5% of patients with HFpEF will have TTR. So that turns into hundreds of thousands of patients that we might be missing with wild type TTR. But the truth is we don't know.
So we may say that using the word rare may not be appropriate anymore for TTR amyloid. But my next question to you is, can you tell us about the impact of specific mutations that have on clinical symptoms or prognosis?
Yeah, absolutely. We have a slide that Dr. Judge and his colleagues is a very nice slide showing the prevalent, showing how common different genes were, the map, in different parts of the world. And if you see here in the United States, that the West African variant from the Val122, or also known as the Val142, all of these have an extra 20 base pairs that were added to the nomenclature a few years back, just to add some confusion to the confusing topic of amyloid. But the Val122 or Val142, very common in the United States. That is very, over 80% of those patients have cardiac manifestations. Depending on which study you look at, there is still a lot of polyneuropathy if you evaluate these patients, but cardiac symptoms certainly predominate in the Val122 variant, and that variant has a worse prognosis compared to other types of TTR. The second most common variant in the US is what's called the Appalachian variant that comes from Ireland, and that's the TH60 or TH80 ALA variant, and that has a lot of autonomic and GI side effects as well as very common cardiac side effects. The Val30 MET is perhaps the most common in the world, and that's very common in Portugal, Brazil, Japan, and Sweden. That is associated with the early onset form with severe polyneuropathy, but also can involve the heart, but to a less frequency than the other two variants that we discussed. there's over 120 mutations, and all of them, even though one might be more likely to cause neuropathy or more likely to cause a cardiomyopathy, all of them can overlap. So just because someone has a specific variant doesn't mean that they can't have features of the other phenotype.
Very interesting. So I do think that people might ask about the staging system, but we can probably reserve that towards the end.
Yeah. I mean, just briefly, the staging is just, really there's a Mayo staging, which is, which is based on BNP and troponin, and then there's a European Gilmore staging system based on a GFR and a NT-BNP level.
So let me just throw one question at you. In your clinical practice, which one do you use, or which one do you find helpful?
For TTR, I'm more likely to use the Gilmore one, which is based on GFR and NT-BNP.
Okay. All right. So with that, we're going to move on to our next guest. It's my pleasure to introduce Dr. Kelty Baker, who contributed to this journal with the light chain amyloidosis epidemiology, staging, and prognostication. She's an assistant professor at Houston Methodist, and she's one of the most brilliant people I know. So I'm going to ask you the first question, Dr. Baker. So if you look at the etiology of AL amyloidosis, what do you think is the relationship with multiple myeloma? Because it gets very confusing, that some people have multiple myeloma and whether they have AL amyloid or not. What are your thoughts about that?
Well, all of these are plasma cell disorders, but you're required to have 10% abnormal clonal plasma cells to make the diagnosis of multiple myeloma. Amyloidosis can either occur as a result of the myeloma, or it can occur in isolation when someone has less than 10% plasma cells. What causes the light chain amyloidosis is when the free light chains being made by the abnormally clonal plasma cells have specific physiochemical properties that make them like to aggregate with each other and form these beta-pleated sheets that we last learned about in biochemistry that then aggregate into very insoluble proteins that are difficult for the body to get rid of. And it's really very idiopathic where the light chains will end up in a given person. Obviously, we're interested in the cardiac patients that we see, but I've seen amyloid in thyroids and breasts and lungs and the urinary system. It can really go anywhere that it wants. In fact, I like to say that although Sir William Osler said, "He who knows syphilis knows medicine," the same thing can be said of amyloidosis. You really have to be on your game and thinking about it and recognizing all the different places that it can go and things that it can do to be able to pick it up in a given patient. Now, y'all were asking about how common TTR amyloid is. We know that light chain amyloid, of all the 30 types of amyloids that are seen in humans, light chains account for 70% of the amyloidoses that we see.
Thank you very much. Barry, do you want to take the next question?
Yeah, so Dr. Baker, so when patients have symptoms related to amyloid, oftentimes they're cardiac in nature, and they're not going to find a hematologist unless someone has been smart enough to order the right test to get them to a hematologist. So a lot of cardiologists aren't really aware of light chain amyloidosis and don't really recognize it in time until oftentimes it's too late. So what would be your message to cardiologists of what they should know about AL amyloidosis and how, and from your hematological perspective, what kind of clues should they be aware of that could get them to you fastest?
Well, I think Dr. Masri is going to go over this to some extent as well. I have had cases sent to me by cardiologists that recognized a low QRS. I've seen it in patients that for a long time their thickened heart was ascribed to their hypertension. And they failed to notice that, oh yes, this person had carpal tunnel syndrome at a young age or at a skinny body habitus. I think the main message that I want to get out is much like what you said about TTR amyloid. It's really not as uncommon as we think. The prevalence is rising, and the incidence is rising because now we have free light chain assays. We're better able to pick up new cases. And then also our treatments are a little bit better, so we have people living for longer. So both incidence and prevalence have gone up in the last 10 to 20 years. I think if we just keep on hitting on people with the message that, you know, if you don't think about it, you will miss it, and try and get it at the forefront of their thought process, we'll get a lot more patients and not have to salvage so many people at end-stage disease levels.
Thank you. Yeah, thank you, Dr. Baker. And then one last question for you, and we'll show the slide you have on staging and the prognosis with staging. I think it's important, with the caveat that this data reflects some older data prior to some newer chemotherapies. But 10 to 15 years ago, when someone had light chain amyloidosis that involved the heart, which it usually does, there was little to no hope for these patients. And I just wanted to get your perspective on how things have changed and in this last 10, 15 years.
Well, like I said, we tend to be making the diagnosis a little bit earlier, but our therapeutics in the hematology world have improved significantly. From when I started my practice, 20 years ago, and we had a handful of treatment options, basically consisting of melphalan, prednisone, and dexamethasone. We've gone to the IMiDs like the Revlimid, to the proteasome inhibitors like Velcade, and now monoclonal antibodies like daratumumab. We've been able to get responses at a level at which we had never previously seen. And unless you obtain a hematologic response, you don't have a very good response. You don't have a very good chance of obtaining an organ response, especially in the heart. I think in the old days, the disease was so advanced and the patient's situation was so dire, you didn't have the time that you needed to, one, shut off the light chain production, but then two, allow the body's own natural resorptive processes deal with the amyloid that was there. I hope that the next therapeutic leap that we will make is acquisition of some drugs that can help us dissolve the amyloid that has already been built up.
Thank you so much, Dr. Baker. So we'll move on to the next article, and this one is, and I'm very pleased to welcome Dr. Ahmad Masri from the Knight Cardiovascular Institute in Oregon. Dr. Masri is the director of their amyloidosis program and of their hypertrophic cardiomyopathy center at OHSU, and very pleased to have him here. And he was the senior author on the paper on the clinical clues and the diagnostic workup of amyloidosis. So thank you, Dr. Masri, for being here. Our first question to you is, I hear from a lot of doctors even now that they've never seen a case of amyloidosis. So what do you say to, especially cardiologists that say this, that read 10 echoes a day? What do you say to these doctors?
Well, thank you, and happy to be here with you today. So what I would say is, I think Dr. Baker said it best, is that if you don't look for amyloid, you're not going to find it. And I think one of the biggest challenges is that we've engraved into people's mind that they need to look at the most severe phenotype of amyloid to call something amyloidosis. The reality is most patients live and die with an intermediate phenotype on echocardiography, not the most severe classic phenotype that typically is people think about. And so I think if one follows simple rules of trying to explain symptoms, explain findings on echocardiography that typically get attributed to a multitude of different things, if one gets into the habit of that, they're going to be surprised of how much they'll find not just of amyloid, of other cardiomyopathies as well.
That's an excellent point, Dr. Mastri. So on that note, could you give us some clinical clues that you would suggest the providers and cardiologists to look for that could lead them in the direction of amyloid, and secondly, some of the echo features that would be suggestive of amyloidosis?
Sure. I think the first thing to think about is, does the patient have heart failure or not? For patients who don't have heart failure, but you're still seeing them in the clinic, I do believe that inquiring about carpal tunnel syndrome or surgery in someone who's above the age of 60 without really convincing factors such as trauma, rheumatological conditions, or occupational exposure, especially when bilateral, I think that's a very high yield question. It's a very simple question to ask patients. And as Mazhan and his colleagues have shown, that 2 to 3% already would have even clinical disease that wasn't discovered before, and up to 10% would have deposits undergoing surgery. And so, not necessarily suggesting that every surgeon should change their practice at once. Maybe they should try to. We've changed our practice here and been very helpful. But at least for cardiologists and for primary care physicians seeing these patients, in general, you can just get into the habit of inquiring about that. Spinal stenosis is another one. And then try always to explain neuropathy. I know a lot of the times neuropathy get, just people say idiopathic neuropathy or just blame whatever. But really, even in the absence of significant heart failure, right now TTR gene sequencing is not part of neuropathy workup, unexplained neuropathy workup, but it probably should be, especially if there are multiple clues alongside that. When we talk about cardiac patients in particular, I think one needs to get into the habit of thinking about heart failure, especially HFpEF or heart failure with intermediate range. What the other features are going on with the patient, and can they give you a clue, such as if someone has autonomic dysfunction, that really is out of proportion to the degree of heart failure. Anyone who have LVH, if one gets into the habit of trying to explain LVH, it's fine if you think it's related to hypertension, but you really have to convince yourself as be able to stand, in a room and convince others that this is just because of hypertension. The combination of EKG and echo are powerful. So if you see LVH on echo, but then your EKG shows low voltage, that is a much better marker compared to just looking at each of them separate. In the setting of aortic stenosis, having LVH as well as having other clues on echo can be helpful if you keep that in mind. And then NT-proBNP is a very powerful marker in the right settings. So if you have someone who is in heart failure and they have a very discrepant looking NT-proBNP as an outpatient, that's a good marker. If you have somebody with, who feels really well and their NT-proBNP is fairly high in the thousands range, that's another clue there. And then atrial flutter or fibrillation, especially atrial fibrillation in patients who don't have the usual risk factors, in patients who are not, don't have metabolic syndrome or not obese, no significant alcohol use, no long-standing history of hypertension, things like that. Those are also other clues to consider. Now, your last point was about echocardiography. There are actually a couple of things that can be really easily followed in every practices and can capture a lot of these cases. One of them is, I know I said that already, explain all LVH. So, in my practice, all my patients have LVH with different etiologies. And so if one gets into the habit of explaining all LVH, you're going to be surprised, or people would be surprised with what they find, even in the setting of significant hypertension or significant kidney disease. And combining that with the story would make one arrive to the right diagnosis. Sometimes you have two etiologies. So sometimes you have long-standing hypertension, and then now you have something else happening, such as superimposed amyloidosis. A reminder that almost 50% of patients with amyloid have had history of hypertension at some point. If it's getting under easier control, that's another clue there. When people have an LVF of 50% plus minus 5%, try to explain that also. It's not normal to be the case. It's not normal to have such an ejection fraction. And so if one doesn't just blame that on high blood pressure or other things and thinks about why someone has such an EF, that's also helpful. And then I know that a lot of people don't have access to strain for everybody with LVH, but you can actually use S prime as a surrogate, because so S prime using tissue Doppler at the bases, especially the lateral base, if you have an S prime 6 centimeter or below, it is a good surrogate for depressed longitudinal motion of the bases. And so even if you don't have strain, global longitudinal strain, you can just use S prime as a way to screen who should you think about more in terms of amyloidosis.
That's an excellent summary, Dr. Masri. Thank you so much. With that, I'm going to introduce our next guest. It's Dr. Mahwash Amala, who's a professor of...
Sorry, one housekeeping thing before we before we move on. We're going to make sure that the audience that's watching has access to be able to ask questions. So we do want this to be interactive. So if you do have questions, you can go to poll EV, and we'll put this on the screen, pollev.com/DEBAKEY, or you can text DEBAKEY, DEBAKEY, to 37607 to join, and then text your message. So either one of those messages, you can ask us questions, and we'll be happy to address them to our guest speakers. So sorry to interrupt. Go ahead, Dr. Kassi.
All right. So with that, I'll introduce Dr. Mahwash Amala. He's the director of cardiovascular PET and CT program. He's a professor of cardiology at Houston Methodist, and he is an excellent researcher. He's the author on the article called "It Takes a Village" with treatment multimodality imaging of cardiac amyloidosis. So Barry, do you want to ask him the first question?
Yeah, Dr. Amala, thank you for being here.
For having me. Congratulations for a great issue.
Well, thank you and everyone here for helping to make that happen. So the first question is, that there's a lot of overwhelming use of technetium pyrophosphate now in the community, now that people are aware of it, and which is great, but oftentimes it's being used inappropriately. Sometimes people are looking for AL amyloid and they're ordering PYPs. So I think it's not always being used in the same fashion that it was in the trials that it was designed for. So can you kind of make a brief summary on the correct use of the PYP, and maybe go through some of the pitfalls, and especially thinking about someone who wants to start incorporating this into their practice, and how would you advise them?
Absolutely. Well, I mean, PYP, the beauty of this technique is that it's an easy technique. It is kind of reproducible if done the same way and done using the appropriate methods, and doesn't require like an advanced system. Any SPECT camera available in many cardiologists' offices can do it. The main thing is that when does it fit in the workup of these patients? The first thing is that you have to have a patient that you have suspicion of amyloidosis based on echo or CMR, and have ruled out AL amyloidosis by checking the kappa and lambda and the proteins. Then you go to PYP. You cannot just jump to PYP before checking the proteins, because this is what probably one of the most common pitfalls in the practices, where people are just screening based on echo and not checking kappa lambda, and some of these patients later on turn out to be AL amyloidosis. So that's something very important. So when it is done, it is, now I know a lot in the beginning the focus was primarily on the planar images, and now we're moving more towards SPECT imaging, because we're noticing that we could get some pitfalls in the diagnosis when you are using just planar images. So think of it like the planar image gives you a chest x-ray, while the SPECT image is going to give you a CT. So now you have more delineation of where the PYP is coming from, where is it uptaken. Because one of the common reasons these patients have low flow state, they have low ejection fraction sometimes, and what we notice is that there could be blood pooling. Now, it may not be that easy to make that distinction based on planar images. So it's very important that we do SPECT imaging, and now the new edition or new iteration of the guidelines really encourages to do SPECT images to be able to differentiate some of the mimickers, I would say, from planar images. It's not about the ratio alone. You have to make sure that the uptake is in the myocardium. If you have access to a SPECT CT system, that will make it even better, because now you can even localize it and see that the PYP is uptaken by the myocardium rather than it is not, it's rather than being in the blood pool. So it's very important to try to make these simple steps, which make a huge difference in the management of these patients, and potentially avoid unnecessary additional testing in these sick patients.
Thank you, Dr. Amala. So one question that often comes up is that, when you've had the kappa lambda ratio, let's say you started from an echocardiogram, you did the kappa lambda, and then you did PYP scan. What is the role of MRI, or how important is it to get an MRI on these patients?
Yeah, so MRI is important, I would say, before you do the PYP, because most often the echocardiogram, there are many patients who have difficult echo windows. You may not, there are multiple mimickers that you can see on echocardiography for hypertrophy, and you're not pretty sure about whether this is hypertrophic cardiomyopathy or some other form of restrictive cardiomyopathy or hypertensive heart disease. These are kind of the most common kind of mimickers, and you want to be sure. This is where MRI would come. So MRI would, I would say, come before the PYP, not after the PYP. So you would like to know that what you are dealing with, MRI gives you two very important signs. The pattern of late gadolinium enhancement on MRI is very helpful, and it has high sensitivity and specificity for amyloid. But that could be seen in both AL and ATTR amyloidosis. And all the MRI measures that try to differentiate between AL and ATTR are very close by. There are some studies that attempted that using some like T1 mapping and others, but they are very close by, and there is significant overlap between these values. So it's not gonna be possible to make that differentiation, and this is where PYP would fit in. MRI is helpful to establish the diagnosis of amyloidosis, and then PYP is gonna come in to make the distinction between AL versus ATTR amyloidosis. MRI also adds the ECV pattern, which is highly prognostic. In fact, it's one of the best prognostic markers in amyloidosis, and has been shown by some studies. So it's very important if you're looking for this information to prognosticate your patients, it's helpful. Now, someone could say, if I have a classic echo, excellent image quality, and I have good strain pattern, and good image on the strain pattern, I'm pretty sure the clinical story fits in very well. Do I need to go into an MRI? If you are pretty confident by the echocardiography, then MRI becomes more of a confirmatory tool rather than it's adding in terms of the management of these patients. So in that case, you may potentially say, okay, I'm going to go echo, get the kappa lambda, and rule out AL amyloidosis, and then move on to PYP and decide on the management based on what I find.
Excellent.
Okay, thank you, Dr. Dr. Amala, excuse me. Thank you both. So the next topic, we're going to turn towards the article written by Dr. Lily Stern and Dr. Jake Patel. And Dr. Patel is here representing that article, and we're very grateful. Dr. Patel is a clinical professor of medicine at Cedars-Sinai. He's certainly a worldwide expert in amyloid and heart transplantation. And while all of us have these beautiful fake Zoom backgrounds, he is naturally showing the LA sun and palm trees in his window. And thank you for being here, and we really appreciate your contribution to the journal. So So, Dr. Patel, if you could just kind of walk us through your treatment, and your article, of course, was on the treatment of amyloidosis, and if you could walk us through your typical treatment for a wild type or hereditary TTR patient.
Well, Barry, thank you for having me and giving us the opportunity to write in this great collection of articles here, very timely. With regard to approach to treating wild-type ATTR, I think one needs to focus on three things: treating the symptoms, disease, and importantly, managing expectations. With regard to symptom management, the thing that patients most complain about are their symptoms related to heart failure. And so this requires adequate education regarding lifestyle changes, and then therapies using loop diuretics, and often bioavailable loop diuretics such as bumetanide and torsemide tend to be more effective in these patients who have biventricular dysfunction and elevated venous filling pressures that can impair renal perfusion. The use of spironolactone or eplerenone may be considered, and lately, the question of whether SGLT2 inhibitors may have a role in these patients is of interest. It's important to note that most of the studies relating to SGLT2 inhibitors in heart failure with preserved ejection fraction excluded amyloid patients, although, as we heard earlier, there are probably a lot of amyloid patients in that subgroup of patients with HFpEF just not diagnosed. Importantly, many of these patients have arrhythmias, and atrial fibrillation may be present in 60 to 70% of these patients, and can be quite a challenge to manage. These patients can have problems with rate control, and as soon as they develop atrial fibrillation, they become very symptomatic. Attempts to correct the arrhythmia can be challenging because of the infiltrative nature of the disease and the resulting remodeling of atrial chambers. And so cardioversions can be very limited in efficacy. And Mayo study has also shown that a lot of patients actually can't undergo cardioversion because they have a left atrial thrombus, even in the setting of anticoagulation. Other arrhythmias are also important, including the development of heart block, and patients may need pacemaker placement. And the issue of blood pressure management may become important. As Dr. Masri mentioned, half the patients may have a history of hypertension, but as the disease progresses, there is a phenomenon of autocorrection of hypertension, and these patients frequently end up with low blood pressure, requiring medications to be peeled off. Focusing on treatment of the disease itself, we only have one medication, tafamidis, which is FDA approved. And it's important to manage expectations for patients with regard to this, because it is the medication is really designed to affect survival, and the ATTRACT study showed an improvement in survival over 30 months. But it really is not a cure, and these patients do have continued a decline in functional capacity and quality of life, albeit more slowly than those patients managed on placebo in the clinical trials. So I often tell patients that the medication is much like a statin or an antihypertensive medication. It's really designed to alter outcomes, but not really manage symptoms. With regard to variant ATTR, heart failure management is pretty much the same as for wild type, but it's really important to assess for neuropathy, because if these patients do have concomitant neuropathy, gene silencers are available for these patients, and that may make a significant impact on not just the neuropathy, but possibly their cardiac condition as well, although clinical trials in this arena are currently ongoing, and we should have answers relating to that fairly soon.
Thank you, Dr. Patel. My next question to you, and I think you kind of alluded to that in your discussion in the previous question, is how do you know when your treatment is working in these patients, and what do you tell the patients? When do you want to repeat an echo, or do you look at biomarkers? Is there something that you follow?
That's a really important question. It's probably one of the most common questions that patients will ask once they're on this expensive therapy. Unfortunately, our ability to determine whether treatment is working is very limited. We typically will perform a 6-minute walk test every 6 months just to see how patients are doing. And biomarkers, I think, are helpful to determine progression of disease, particularly proBNP, troponin. And I actually even check pre-albumin. If I've checked it pre-initiation of tafamidis therapy, often you see an increase in pre-albumin levels, and that may be something to reassure patients with, that perhaps the medication is working. With regard to imaging for an individual patient, I think this is much more challenging. You can certainly assess echocardiograms, and a decline in ejection fraction is very concerning for progression of disease despite treatment. And there is certainly evidence to suggest that if you start treatment late, then efficacy may be limited. But quantitative imaging, with whether it's echo, pyrophosphate scan, and MRI, I think we still have a lot more to learn with regard to assessing efficacy of individual therapies.
Thank you, Dr. Patel. And one more question for you, and this relates to something that I know we've spent a lot of time talking about before, is transplant in patients with amyloidosis. When and I know also I should say that you're working on the cardiac amyloid registry to help answer this, multi-institutional registry to help get data to help answer this question. But when generally, what message would you tell other specialists, because I'm sure you get this all the time, of when to pull the trigger for transplant versus staying the course with the treatments you discussed?
Yeah, this is a really difficult area. Generally, we look at patients with advanced disease, New York Heart Class 3 or 4. Many of these patients actually present to us in cardiogenic shock and even get diagnosed at the point of admission with their condition for the first time. With regard to ATTR, the important aspects are to exclude significant extracardiac disease, because the progression of that disease may not get attenuated by cardiac transplantation alone. We look at comorbidities. Remember, many of these patients are elderly. They may have concomitant cardiovascular disease, renal disease, or pulmonary disease, and that can be very limiting. In terms of age, that's a very kind of a soft target. At CEDAS, we've done 63 transplants in amyloid patients, and for wild type, the average age is actually 70, and the oldest one we've done is 78, and he's doing very well in his mid-80s. So I think assessment of frailty and physiologic reserve is very important in these patients before assessing a candidacy for heart transplantation, particularly in variant patients who may have concomitant neuropathy and hypotension, which can be very difficult to manage at the time of transplant or post-transplant. With regard to patients with AL cardiac amyloidosis, these patients are ones that we worry about the most because we know that they have a very high mortality, particularly without treatment. And so I have a very low threshold for evaluation. And once the evaluation has been triggered, I will follow their response to chemotherapy with regard to symptoms, cardiac parameters, proBNP, and free light chains. And we know from the literature that a decline in proBNP of greater than 30% is associated with improvement in survival, and maybe a good prognostic factor. But a lot of these patients actually do get better just by treating their free light chains, because those free light chains are directly toxic to the myocardium. And while you've not done much to the amyloid that's already there, by just simply reducing free light chain burden, these patients actually improve symptomatically. And many of these patients subsequently do not require transplantation. Those that do require transplantation are the most challenging, perhaps, to manage, because they do have a higher post-transplant mortality, although in our program, 1-year survival is in the percent range. Many of these patients will go on with chemotherapy post-heart transplant, and we typically will resume chemotherapy at 3 months post-transplant, with the aim of assessing them at 1 year with regard to the need for an autologous stem cell transplant. Although, given that the treatments now are so good for AL amyloidosis, not many of those patients are actually needing an autologous stem cell transplant following heart transplant. So of the 17 AL patients we've done at our institution, only 5 have needed to go on to an autologous stem cell transplant.
Thank you, Dr. Patel. That's an excellent overview of this very complicated topic. Moving on to our next guest, Dr. Roslani. She's an advanced heart failure transplant cardiologist at Montefiore, and she's joining us from New York. Her contribution to this journal is on epidemiology, pathogenesis, and diagnosis of cardiac sarcoidosis, which is another, I would say, orphan disease that we are very much interested in, and there's a lot of overlap sometimes in diagnostics that we go through for amyloid as well. So my first question to you, Dr. Roslani, is how prevalent do you think cardiac sarcoidosis is?
Thank you for having me, Dr. Kassi, and thank you for the opportunity to contribute to this this compilation that you guys have put together. So, sarcoid, as we know, is a multi-system disease, and in general, the prevalence is estimated to be anywhere from 5 to 65 per 100,000 individuals. It varies based on race, varies based on geography, and it's most common in individuals of Scandinavian descent, which is Northern European descent, or African Americans. It's 3 to 4 times more common within the United States. It's 3 to 4 times more common in Black Americans compared to other racial groups. Cardiac sarcoid per se, it's a subset of sarcoidosis in general. It could be the only manifestation of sarcoidosis, or you could have cardiac sarcoidosis in conjunction with other organ system involvement. And based on the literature, we know that about a third of patients with sarcoidosis have cardiac involvement, but not all of them may be symptomatic. We know that, and we know this based on autopsy studies, MRI studies in these populations. Only about 5% of these patients actually have symptomatic cardiac sarcoid, which typically presents with conduction system disease, ventricular arrhythmias, or heart failure. If you were to flip this question around and think about how many patients with heart failure that we see might have cardiac sarcoid, or how many patients with conduction system disease that we see on a daily basis might have cardiac sarcoid, there are registry-based data that show that may be a significant number of patients. So I think the simple answer to your question is, it's much more prevalent than we currently believe. There's data from Finland and Canada, registry-based studies that show that in patients under the age of 60 presenting with new AV block, up to 30% of these patients have either sarcoid or giant cell or some sort of an inflammatory process as the etiology for their AV block. Fewer studies with heart failure, but if you look at, there are a few studies that look at transplanted hearts, LVAD cores, and up to 5% of these patients have cardiac sarcoid that is retrospectively diagnosed at the time of transplant or at the time of LVAD. The prevalence, of course, over the last 20 years or so has gone up. There's a nice study from Finland that shows that it's increased by over 20% over the last 20 years or so. And that's likely because of the utilization of all the advanced imaging techniques that we have now that can help us with diagnosis of cardiac sarcoidosis.
Dr. Roslani, thank you for being here. We have the slide up that you guys created in the journal about your diagnostic pathway. If you can just kind of briefly walk us through your diagnostic algorithm, especially in light of the fact that we know the sensitivity of a biopsy is so poor, and we always try and want to get that biopsy, but oftentimes we fail, and we're still left with a patient we need to treat that we need to figure out how much we suspect that they actually have sarcoidosis. Can you walk us through your diagnostic pathway?
Of course, yeah. So, it's a difficult disease to diagnose, mostly because require a combination of clinical imaging as well as histological findings to actually diagnose this disease. In the pathway, that I've suggested in the paper, I think the way to think about this really is what is the patient population that you're looking at? Are you looking at a patient who has extra cardiac sarcoidosis and you're screening them for cardiac sarcoidosis? Versus are you looking at someone who's coming in with clinical manifestations that make you suspect a diagnosis of cardiac sarcoidosis? So, if you have someone who comes in with idiopathic heart failure and echo shows, no coronary disease, echo with regional valve motion abnormalities, and there is a suspicion for sarcoid, or if you have someone who presents with new conduction system disease under the age of 60 or idiopathic ventricular arrhythmias, you should ideally start screening with an MRI with contrast. This will help you not only, think about sarcoidosis as a possible diagnosis, but MRI for non-ischemic cardiomyopathies also could give you a suggestion for any alternative etiologies for these manifestations. If the MRI is positive and shows the typical findings of patchy mid-myocardial, subepicardial, late cadaveric enhancement, the next step would then be, in a person who does not have a known diagnosis of systemic sarcoidosis, the next step would then be a whole body PET scan. This will help you figure out if there's active inflammation in the heart or outside, which could include mediastinal nodes, lung, liver, lymph nodes anywhere else, anywhere else or any other organs. And this can then guide you to what you could biopsy to get the histological diagnosis, which can be very, very challenging, particularly with the heart, because endomyocardial biopsies are typically done through the RV, and the yield for cardiac sarcoid is only about 20 to 30%. And we know why that is, because on pathology studies, that the granulomas are mostly subepicardial, mid-myocardial, which is, hard to reach. And then they're also at the base of the septum and the lateral wall of the LV most commonly, which is very hard to get to also with the typical, you don't get to those areas with the typical endomyocardial biopsy. So, and that's why it's important to do the whole body PET, figure out if there are any areas that light up that you could potentially use to get a histological diagnosis. And if that doesn't pan out and you just have inflammation in the heart, you can do a more thorough screening with still doing chest imaging to see if there's scarring in the lungs, anything else to suggest stigmata of pulmonary sarcoid, looking for uveitis in the eyes, asking about skin lesions. Skin cutaneous sarcoid can have like a relapsing remitting course. And a lot of patients I see in my practice will tell me, I had all these lesions that would come and go. And you could easily do a skin biopsy in these patients to establish a diagnosis of sarcoidosis. In patients, in the second group of patients, where you're screening patients who already have systemic disease for cardiac involvement, typically we start with just a history to check if they have episodes of syncope, if they have any symptoms of heart failure, if they have any clinical suggestion to see they may have cardiac, any sort of cardiac pathology. And then an EKG to look for conduction system disease, bundle branch blocks that you cannot explain, frequent PVCs, high PVC burden, and then an echocardiogram with echo features that might show, basal septal thinning or regional valve motion abnormalities, inferobasal aneurysm, things, and in the absence of coronary disease. So all these, or a Holter study, with arrhythmias or high PVC burden. If all of this is negative in a patient with systemic sarcoidosis, you don't usually recommend screening further with an MRI. It's not really being done outside of research because we don't know what to do with these patients, whether they warrant treatment or not. And the guidelines actually don't even, the 2014 HRS guidelines don't even recommend repeat screening. But typically in my practice, these patients follow with a rheumatologist who will get an annual EKG, just make sure nothing has changed, check for symptoms, and refer them if they have any clinical change.
That was an excellent overview, Dr. Chalani. Thank you so much. With that, I want to acknowledge Dr. Papankolo and his group and Greece, who basically couldn't join us because of the change in timings, because it's very early in the morning right now. But he and his group contributed to the state-of-art treatments for sarcoidosis. We're very grateful to him for this contribution, and it has some nuances on who should be treated, how should we treat them, what are the up-and-coming, some of the trials that are going on for cardiac sarcoidosis. With that, next, I think, Barry, what does the future hold for TTR amyloid? I'm going to go back to that briefly, and if you want to just comment on some of the newer treatment options.
Yeah, I mean, I think there's certainly exciting developments in terms of new RNA silencers that are subcutaneous, and CRISPR technology, which is really exciting, which is gene editing that they've done successfully in 6 patients and are looking for more trials in that. I do want to save time. We do have a few questions from the audience, and I wish we could go into all the new exciting developments in amyloid and sarcoid, but I do want to let the audience ask some questions. I'll take the first one is, do we have to be concerned about amyloidosis with mild LVH? And I'll punt that to Dr. Masri.
So excellent question. I think really it's the whole story that might make sense. It depends. So if someone has some family history, something concerning, African American patient, no history of hypertension whatsoever, they have an elevated NT-proBNP, even if you have mild LVH. In women, we tend to say that women and men should have the same degree of thickness, but that's not true. Women typically tend to have 2 millimeter or so less thickness. I don't think essentially in someone who is elderly, who has some history of hypertension and metabolic syndrome necessarily, and there are no other red flags, just isolated mild LVH probably would be low yield for amyloidosis. But if you have multiple red flags at the same time, including some orthopedic red flags, I think that would warrant an investigation, yes, if there could be amyloidosis there or not.
CMR in every elderly who has hypertension or severe aortic stenosis with clinical heart failure. I think that sounds like somebody who's very frustrated with the workup for amyloid, but what do you recommend? I think I'll open this question to Dr. Patel and Dr. Masri both. When should you start looking for amyloid?
I think the important aspect of making a diagnosis, as Dr. Masri mentioned, is really the clinical presentation. And if you start looking for the typical red flag symptoms that are associated with cardiac amyloidosis, then your ability to pick up the disease is much higher with subsequent imaging modalities. And there are multiple red flag symptoms that we look for. Dr. Masri mentioned carpal tunnel syndrome. So these patients are also at risk of developing spinal stenosis due to deposition of amyloid in the ligamentum flavum. They're more prone to tendon rupture, particularly biceps tendon rupture, rotator cuff injuries, and multiple arthroplasties as well. And I teach my residents and fellows to really specifically look for those red flag symptoms. And if you have a cluster of them, there is a very high likelihood that you're going to make a diagnosis of cardiac amyloidosis. So that's my starting point.
If I can interject, the symptom that's seen in the vast majority of amyloid patients is weight loss. That's seen in 95% of patients with light chain amyloid. So that would be another good thing to look for.
I'm sort of taken by the increased incidence we're detecting in this elderly group of people that are going for TAVR. And if you have severe AS, but on top of that you have amyloid, the results of TAVR may not be so good. Mm-hmm. I mean, you could, now that CMR is so available, I'm beginning to think you could even build a case, and maybe before doing a TAVR in most of these elderly patients, if they have heart failure, mm-hmm. obviously not all of them do, right. That maybe, we should do a CMR. It's up to 20% in some of these series.
Yeah, absolutely.
I mean, what's wrong with just doing a CMR in every elderly person going for TAVR with severe AS who also clinically have heart failure?
Yeah,
I would be inclined to just say, let's do it.
I definitely want to hear, from our guest speakers. I just would add that, there is data from Adam Castano and looking at just doing a much cheaper technetium pyrophosphate with ruling out free light chains. 16% of patients referred for TAVR did have TTR amyloid. That might be reasonable.
Yeah, that might be even more reasonable.
Any thoughts from our amyloid and imagers? And
if I may add just one thing, data from the UK, when they looked at those with severe AS and concomitant TAVR, the primary outcome of these patients was determined whether they got the treatment for aortic stenosis or not.
Okay.
So irrespective whether you have amyloid or not, they will do better if they had the TAVR compared to those who did not get the TAVR. So it will probably just more alert you that this patient is not gonna do well long term maybe or so, or will have probably worse outcome, more comorbidities or longer length of stay, but still treating the valve is probably important in these cases. So detecting it is probably more of a risk stratifying sign rather than treatment decision tool.
That's a very important point.
Yeah, I definitely think they need more, whether it's MRI or TAVR or just a good history and finding out whether they have the comorbidities of carpal tunnel and lumbar stenosis. I think that would be a very simple thing to do, and I think people are doing that. I do think, we haven't really talked a lot about sarcoidosis treatment. I know our final article was about it, and Dr. Papanikolaou and colleagues from the University of Corfu in Greece are not able to be here, but Dr. Kassi, I know you treat a lot of sarcoid. Can you kind of briefly touch on your general approach to treatment of these patients?
Yes, so I think one of the things that Dr. Roslani mentioned was particularly you have to look for what do they are manifesting with, if they have heart block or heart failure or ventricular arrhythmias, and those are the type of patients you want to treat. Now the general first line of treatment is steroids. However, if you look at the scope of cardiac sarcoidosis, the idea is to kind of go away from treating patients with really high dosages of steroids and try to treat them with steroid-sparing agents. There's a lot of controversy in the world of cardiac sarcoidosis, like in certain centers, once the inflammation resolves by PET scan, some people stop treatment. In some of the other centers, they continue treatment lifelong, thinking that this may come back. In our general experience, what I've seen is that once we discontinue treatment, we see recurrence of disease. So we try to keep them on some kind of immunosuppression, which is steroid sparing. A lot of data out there on methotrexate, particularly in the lung world. But of course, methotrexate, it's a low profile drug, but it has its own nuances and side effects. Some data coming up on CellCept. In our center, we being transplant cardiologists, we are more friends with CellCept, so that's the agent we used. But we've seen more and more data in our own patients. We've compared methotrexate and CellCept and found CellCept to be effective. There are other, of course, agents. There's a lot of hype about whether we should be using TNF inhibitors or not in patients, particularly with heart failure. And there is a case series from Stanford and from other centers where we've used this agent safely in patients, even when they have decompensated or heart failure, not decompensated. So you want to make sure that they're well compensated before you start this agent, and then watch them for any decompensation. But generally speaking, they respond very well, and it's a good agent to use. There is, for the first time, some randomized clinical trials going on, which are on the use of high versus low dose steroids plus methotrexate versus conventional just steroid therapy. There's one trial going on some interleukin 1 and 6 therapies, and there's some transcriptomic studies that suggest that infectious agents such as even tuberculosis and propionibacterium cause sarcoidosis as a second hit hypothesis and trigger sarcoidosis in patients. So there's a study going on in Japan where they're using some antibiotic type of therapy to suppress propionibacterium to prevent a progression of sarcoidosis. It's a very intriguing and interesting disease with a lot of overlap, and sometimes we even see some of the kappa lambda being abnormal in these patients, and the final conclusive diagnosis is actually sarcoidosis. So one last, I think my comment would be to beware. Sometimes we do see overlap between amyloid and sarcoid, and you have to really know the differential diagnosis, as AJ mentioned at the beginning of this talk, of what you're dealing with.
Great. And I think we're about done with time. We do have one final question from the audience I wanted to get to. This is a great question, and I think it's a good one to end with. It's the earlier we detect amyloidosis, the higher the likelihood of successful treatment. How do we detect before heart failure is manifested? And I'm going to open that up to any of our amyloid experts that want to take that question.
So, I think beyond the clinical signs and presentations of the red flag symptoms that I mentioned, there are newer technologies that are looking at the ability to pick up amyloid early. We have a program at CDIS that's using artificial intelligence at screening routine echocardiograms, and finding it very helpful that we're able to distinguish causes of left ventricular hypertrophy on an echocardiogram just by using AI algorithms with our ability to pick up amyloid quite well. So we're actually doing a prospective study right now, screening patients who have a suggestion of amyloid but haven't been diagnosed with amyloid, and we'll see where that data lands. There are other approaches to this as well, using ECGs from the Mayo Group and also MRI technologies as well.
From the hematologic standpoint, if you have a TTR, obviously you're going to be able to diagnose it in the children much earlier than you did in the index patient. There's also some familial predisposition in the lymphoproliferative disorders. MGUSs and lymphoproliferative disorders travel in packs. So I pay a lot more attention to an MGUS patient that has a family history of amyloid than I do to a regular MGUS patient. But again, the hematologist has to be very alert to changes in their patient status and reports of neuropathy or some fluid retention or increased bruising. I don't mind if a cardiologist misses an amyloid. I mind a lot if a hematologist that's been following the patient for MGUS misses it.
The answer to this last question is, number one, the astute history taking, and number two, stay tuned, because hopefully we might be able to eventually have tools to help us answer that question, which I think is a very important question. The hour passes very fast, and we are towards the end of it. I hope that all of you have learned something from these two so enigmatic diseases that clearly are becoming more frequent now that we can detect them. I have learned a lot tonight. But please, go to the journal, read the articles, because you will learn a lot more if you do that. So I personally want to thank all of the authors who have participated tonight on this webcast. You guys have done a fantastic job. Thank you very much. And of course, our two guest editors, Dr. Trachtenberg and Dr. Kassi, who put all this together. It's time to go home. Good night.
Thank you.